it a couple of times at Exeter, and it's almost as much of a session as much as about a sermon, because this is something that really does matter to me, because I've seen it done relatively poorly in a few different areas. So I'd like to talk about some of my experiences and why it matters to me. So as an outline, I'll tell you a bit about my background, which is a bit atypical when we're thinking about research. Talk to you about why these approaches are important, some information about practical considerations, and I'm going to move on to a practical example of how I've actually been able to run a project with meaningful participation that's moved on to actionable change. I'm then going to lean on some of my experience doing lots of different types of evaluations, talk to you about engagement and what that means in terms of outcomes and in terms of impact, which we know is particularly important for research going forward, and then a few take-home messages. So my background, whenever I bring this picture up, I don't really look like this anymore, but my colleagues say I look like Badly Drawn Boy, and some of you might know that particular singer. But I love the picture, so I just keep it up, even if it looks a bit different hold up now. I'm an applied psychologist, as Claire said, at the University of Exeter, and I work as an embedded researcher. And what that means is that I work alongside lots of services and systems and do my research whilst services are being delivered. So I don't necessarily take my research out of the context. I work alongside teams to think about what we can do and what we can improve. My specialisms are in improvement and implementation science. So again, I'm looking to make changes in practice, and that does involve being a bit of a generalist. So in some ways, I'm a methodologist, but also I'm a bit of a broker of knowledge. So with a lot of the research that I do, I don't have to hold the subject expertise. I'm very interested in bringing in the right people through different lenses to think about how we can make changes and how we can make improvements in sometimes really difficult areas of research, and in particular mental health. My background is atypical and it's really quite varied, and I'll just mention a couple of things that I've done in my experience. So I do have really quite a good track record of making improvements in some of the really difficult areas of mental health. Alongside that, I've taught leadership and improvement to a master's level. I've worked with a lot of clinical leads about how they can enhance their research skills and supervise many teams across some of the, like I said, some of the more difficult areas of research and mental health. So I've done work in things such as reducing restricted practice, in particular, reducing seclusions in a forensic ward. And that's one of the publications I had this year. And worked with a specialist eating disorders unit, looking at how we can reduce eating disorder behaviours. Done other areas such as integrating nature-based approaches in CAM settings to increase therapeutic relationships, but also how we can use nature-based approaches for de-escalation and for violence and aggression in forensic settings. I've worked on a national level with the Care Quality Commission for how we can create national guidance to do things such as reduce ligature harm and the therapeutic use of enhanced observation. So some of the more acute, more difficult ends of mental health. But going forward, my real interest, my real passion from last summer, and I've been very, very grateful to be awarded some funding from the 3 schools, is to look at men's mental health, and in particular look at how we can consider male suicidality, the role of community services, and then how they integrate into primary care settings. So when someone does present with a risk of suicide, how we can look to support them from informal to formal settings. And beyond academia, well, I mentioned I've got some real experience of evaluation. I did work for the Medical Research Council before being at Oxford, which was before I was at Exeter. And I developed the first iteration for how they evaluated Health Data Research UK, which was a 10-funder investment with, I think it was about £125 million. I've worked in other areas such as looking at how we can increase the access to social welfare law information advice in North Somerset, and done some work in the education sector, looking at how we can provide initiatives and opportunities for underprivileged children and their families. So you can see that generalist approach. I've been involved in lots of different things. But regardless of what I've worked on, it's always been based on sort of 2 core principles, which is making sure that when we are making changes or we're doing research or improvement or innovation or whatever you want to call it, that we have the right people involved and we have them engaged when we are looking to make changes. This is really important because if you think about research, it doesn't matter how great your evidence base is, how perfect your design is. If you're looking to make changes in practice and those people aren't engaged, it's a bit neither here nor there. So making sure we have the right people in the room to have these conversations, to look to inform these changes is really important. From a mental health perspective, I'm really interested in how we can take that individualized person-centered approach. And I intentionally say person-centered, not patient-centered, because we do need to think about how we support patients or service users, depending on the terminology you use. But we also need to think about staff that are involved and think about, well, what do the changes mean to them and how do we need to have them involved in these conversations? But coming back to patients, it's really about understanding how we can engage with them and how we can empower individuals to not be passive in their recovery, but to take an active role in their recovery. It really does matter to me. And the reason why it matters to me is because I have lived experience. I've had my own mental health challenges. I've accessed mental health services. I have a really intrinsic motivation, not just to do research for the sake of it, but to get involved in things where I can see vulnerable populations that need the support and to try and make a change, try and turn the dial as much as I can to make a difference. And alongside that, I've done charity work. I've volunteered as a Samaritan. I've done various different things like befriending. So I really want to paint the picture of why this matters to me and the kind of research that I've done to build me up to why beyond tokenism and meaningful participation matters. So why are these approaches important? The meaningful participation and how we get towards actionable change. So I want to ask, and you don't have to speak out. Please just type in the text box. That's absolutely fine because and Claire, I know you'll help me, but if I've got people talking and texting, it will go to mush. I want everyone to answer this question. Have you ever been to a meeting and come out not knowing why you were invited? Say yes, and then tell me how it made you feel. Hopefully this won't be one of those meetings. Hopefully you'll come at the end of this and say, I know why I was invited. This was worth coming to. But if you could, yeah, so yes and frustrated. Yeah, confused. Like an imposter. Yeah, absolutely. Isolated, anxious, annoyed. Yeah, yeah. I'm just watching people type, by the way. I'm not just stopping my talk, I promise. Confused and concerned. I didn't even understand the point of the meeting. Absolutely. Yeah, yeah. That's absolutely fine, I think, for the moment. Feel free to continue contributing, but I'll just move on. So we've asked, how does that make you feel? Well, I think we probably covered a lot of this, right? Did they mean to invite me? I didn't really understand what they were talking about. I mustn't be good at what I do. So the imposter syndrome that Claire mentioned. Um, do they want me involved at this point? I don't think I'll go back. I don't want them thinking I don't know what I'm doing. I don't think I'll volunteer on future projects, right? So we've all been there, okay? We all recognise this. I think even people that haven't typed would recognise that we've all been to a meeting where you come the other end, you thought, well, I don't really know why I was there, and that's a common issue, isn't it? Right. And then my next question to you guys is: have you ever been to an event where you felt really hyped up about what was being discussed, and then nothing happens? And then you go to a similar meeting. So you go back to your day-to-day work, and then a bit further down the line, you go to a similar meeting where similar people are saying similar things and nothing's been moved forward. What some people might call a talking shop. How does that make you feel? And again, feel free to type in the text box. I'll be really interested to know if you had this and how does it make you feel? Yeah, again, we're seeing similar things. I'll be frustrated, wasting my time, absolutely. Wasting my time, no point in contributing. Yeah. Yeah, it's draining, so I zone out. Hopefully you won't zone out at this talk. I'm very hopeful of that. sometimes I feel it's a great step. Yeah, no, absolutely. And that's a fair point. That's a fair point. But let's say if you've got to the fourth or fifth iteration of this happening, that might be, and you might start turning your opinion on that. Okay, so again, it's probably going to be the case if you're thinking, well, this is a bit of a waste of my time. Will you continue going to meetings or events that actually end up going nowhere? Some of you already mentioned this sort of is wasting my time. There's no point in contributing. Again, this is a very common thing that we can have happen to us, isn't it? Now, we're all used to coming to online meetings and in-person meetings. I'm assuming that most people are used to this. But imagine if you're someone that's not used to going to these kind of meetings. I have probably 15 of these in my diary just this week. This is really normal for me. But if you're not in that position, and let's say you are someone that turns up and you have lived experience and you're hoping to be able to contribute, or maybe that you're a newly qualified team member, that might be a researcher, that might be a healthcare worker, and let's say that you want to contribute to the way things are done. And it might be you want to contribute because you've had a really good experience and actually you want to pay back the support that you've had. Or it might be that you're someone who's had a really hard time whilst accessing services and you want to be the lever for change. You want to make that change. You might just be a junior member, really, really excited about being able to contribute with a fresh pair of eyes. Think about how that might make you feel and how that might make that person feel. Would they end up coming back again? Were they just at the wrong meeting? And if they were in the meeting, maybe in 2 or 3 meetings time, that was a time when they can contribute, but they may not turn up again. So these are really quite simple questions, but they're profound questions that we really do need to be thinking about when we think about participation, particularly around those people who might not be used to having these meetings and what their role might be. I wrote a paper a few years ago during the pandemic when we were all trying to work out what we could do because I couldn't do any new research. And it was on the ethical considerations of participation. This is actually gaining a lot of citations at the moment, which I'm very pleased with. It's almost turning into a bit of the methods paper. But the point that I was making, or rather me and my co-authors were making, is that goodwill in time is a currency. This is people giving you their time. We need to consider how we spend that and making sure that it's used wisely. We need to think about when people do take time out of their day. When I look at the amount of people here, we think we tot up all the time that people are using to be here. Well, that's a lot. We have several meetings. So think about the practical burdens of when you are bringing people into a meeting, but also some of the emotional burdens. A lot of the work that I do can have emotional burden. And I talk about people de-escalating almost violent situations or aggressive situations. That's a form of positive risk taking. We're saying we want you to hold off from using restrictive practice and think about how you might be able to bring that person down through de-escalation. So think about when we are making changes, what are the emotional burdens as well as practical burdens that we're putting on people. And in particular, when you are looking to make innovations, whether that be research or improvement, you're asking people to step into the unknown. If we didn't need to do research, well, we wouldn't need to do research if it's something we already know. But if it is research, then we don't know that. And for some people, understanding that notion of there might be failure, we don't know whether it's going to work or not, it's really important, especially those people that aren't used to research. So I'm going to move on to the practical considerations for what we consider now when we're thinking about this. I'm sure you know this phrase, but I use it the other way round. Certainly with the NHS, they like to change everything all the time and not necessarily take the time to think about whether it will work and how they'll evaluate it and whether it's the right thing to do. So we're thinking about the burdens that I've mentioned. It's really important. So what I would say is don't just do something. So don't just run ahead. Stand there and listen. Have the right people involved in these conversations. Make sure you've got the right groundwork before you look to make any change. And the ways in which you want to consider this is around how do we have psychologically safe practice? This is an area, I'll put a couple of papers up that I've done in this area because it's a really good one. But psychological safety is about how do we make sure that people feel confident about being able to contribute with ideas, mistakes, or concerns that they see within practice or maybe within research. so they feel safe to be able to contribute, even if they're that junior person, maybe the person with lived experience that isn't used to these meetings. So we want to really think about, does everyone know what we want to achieve, and making sure that we convey that clearly, making sure that we're very, very explicit with the ways in which people are involved and the level of involvement that is expected. When people do join, making sure that they understand how they can contribute, and maybe making some accessibility considerations about how they can contribute. Those people that might not be used to how these meetings run, they understand beforehand how things will look. Consider group dynamics. There's absolutely a role for having people brought together, and you'll see that in my example, but in some situations where you might have different lenses, in other words, different angles that people will look at it, think about how you might set up some of those groups and how you might bring them together. And I'll give you a real example of how I did that in a project. And be explicit with the expectations for behaviors. I'm going to be perfectly honest, I'm a talker, love talking, and I really keep myself in check, So if you're chairing these meetings, be very explicit, equal airtime. And I tell myself this, I'm being really honest, I tell myself this. I get very passionate and I'll talk away and I will stop myself, because it's important that other people know that their viewpoints are equally as important. Confidentiality, of course, with sensitivity, no judgment, that's an obvious thing. Active listening, so we are paying attention to what's being said and showing those cues that we are hearing what's being said. And the right to pass. If you're there, it doesn't mean you need to contribute. You can if you want, but it's fine to pass on. And also to withdraw yourself if things might be a bit difficult. And then think about, of course, issues of accessibility, such as, geographic location, all the things that you probably already know. So now we've considered that, I want to ask this question, we'll turn it back round. So you've had everyone involved, you've had the groundwork, and now you're thinking to yourself, okay, well, we've had our talking shop. It might have been a few times, maybe one more time than we need. But don't just stand there. Now you've had people's input. Do something and bring people along with you. It's really important that you bring people along with you when you are looking to make changes, that you have got the relevant people involved in any changes or research that you're doing. Because we've all been in this situation, haven't we? Where we've contributed to things. You've done a survey, or you've done a focus group, or you've been in a workshop, and it looks a little bit, this is where I use the stock images, by the way, Claire. I love a stock image. But it sort of looks at this, right? You go in, you give your time, you're all infused, and it feels like it goes into a bit of a black box. And then all of a sudden, 8 months down the line, you might bump into the publication or report that's been given. You have no idea how they've got from the input that you've given to the dissemination that's come out the other end. So it's really important to bring people along with you. And if they have given you their time, really understand how you might have them involved in those conversations going forward. So, of course, to avoid such issues, you want to be thinking about your transparency of methodology. And from a research perspective, that's really important for robustness. But really thinking about how you can record where people are giving you input, how you've analysed it, and how you've acted upon those insights. So a common way we do this is, you said, we did. So you said this, we did this. Doesn't mean you have to act on everything, but at least acknowledge what's being provided. Think about where you might do dissemination and think strategically. The amount of times I've been in big meetings where they've just said, well, we'll do an infographic, and they haven't really thought about what the infographic will say or who it will go to. So spend time being strategic with your communication and who you want to reach out to. Be clear and explicit about who will be carrying this work going forward, and build a core team. Not everyone needs to be involved in everything, but think about the core areas, the core people, and who feels really quite strongly about it, and whether you can accommodate them going forward. And foster reciprocal and well-meaning involvement. So be open about what you can and can't do. There's going to be some things that just aren't feasible, aren't realistic. That's okay, but just make sure people know about that. You're acknowledging them, acknowledging what they've provided. And the thing that I can say the NHS do really, really badly is acknowledge and celebrate involvement throughout in a sincere way. The amount of times I've supported teams, I've had to tell them, go and be loud and proud about the work that you've done, and bring the people who've been involved along with you. And don't be modest, and don't say this is just what we do. you know, making sure that when people are involved, that it really is acknowledged, because you'll foster those opportunities in the future where they'll be able to provide information and help with any future projects. Okay, so at this point, I've taken through some practical considerations, a couple of papers, stuff about why this matters, and a few, dare I say it, meme-like sayings to really sort of ground why I think active participation or meaningful participation that moves to actionable change is important. But you might be thinking to yourself, well, this all sounds really interesting, but well, how on earth do we do this? And if you're thinking that, you're making a good point. So now I'm going to tell you about how I've actually carried out a project when I worked at Oxford before I was at Exeter, and how I looked about having that meaningful engagement, and it did lead to actionable change. So the project that I'm going to talk about is about a year ago now. There was a national change in the ways in which care planning was done. The care planning approach, CPA, was removed, and it meant that there were some shifts in terms of how care planning is done within mental health services. And this is particularly important because when we are thinking about care planning, this is about how we understand individuals, how do we consider safety plans, and also how do we think holistically about the different aspects of what matters in their lives, maybe about the treatments that they may require, integration with wider services, and also how we might be able to record their progress and how they're getting on, as well as other things like communication preferences. And it's a really important area when we're thinking about mental health services, because when we take the opportunity to understand the complexities of someone's life, so in other words, they're not just a diagnosis or a symptom, we think about things such as interpersonal relationships, those things that are purpose building, such as training and occupational opportunities, relationships, family, leisure activity, all sorts of things, accommodation. You can see that we can build a complex picture of what their day-to-day life looks like. And when we do that well, it helps in terms of positive outcomes, helps with patient engagement, and also helps with their relationship with the service. But when it's done badly, this is where, you know, people might feel that they're actually just what I call feeding the beast. So they're just plowing in lots and lots of information for the service and for their needs, but it's not really about actually how the service can then support them with their mental health challenges. Then that can have lots of negative impacts, as you'd expect, in terms of experience, disengagement with services, adherence to medication. It can have really quite a big impact. But thinking about care planning is really important because it's vital for that recovery-oriented practice approach. So that's about working alongside patients, understanding what their strengths are, and building hope, and really helping them take an active and collaborative role towards their own recovery. It really does matter. So the approach that I've used is what's called appreciative inquiry, and some of you might know this. I adapted it a little bit, and I'll explain in a second. But appreciative inquiry is basically a strength-based approach in which you look to understand and appreciate what's happening within a service or an ecosystem, depending on how you want to see it. And you draw upon the strengths of individuals and organizations, and you use that as a foundation for how you can build what needs to be done, what innovation might be needed, or what research might be needed. That's the appreciation. The inquiry is about how we use a 4D cycle. So this is a structured approach, which I'll mention in the next slide, but it's about how we move from a shared vision towards what we can actually do about it. And I'll explain that a bit more. And then there's a wholeness approach, which is about recognizing that we do need to have the relevant people that are involved in the system. We do need to make sure that we've got junior and senior staff, anyone who has a stake in whatever's being changed or innovated or maybe researched does need to be there, that whole system perspective, different lenses, as I mentioned earlier. So the 4D cycle is, I never liked these terms. I've got to admit, when I first saw them, I thought DREAM was way too American for my liking, but they do work. They really do work. So discovery is about really narrative sharing, about people talking about their positive experiences, in this case, of what good care planning and what good collaboration can look like. From those, so we share the stories from those, we move on to the dream phase. So this is where you say, okay, well, we can see these good stories. If we had a magic wand, if we could look forward, what would we want to say it to look like in a year, 2 years, whatever time frame you want to use. So this is about bringing people together in a meaningful way, right? This is the first part. If you stop there, that's a talking shop straight away. Everyone gets very into their thoughts and feelings. That's absolutely fine. The next part changes it into actionable change. And this is when you say, okay, well, this is what we've got. How do we make this happen? What are the changes? And I get really quite straight to this part, and I do forewarn them so they don't get caught out. This is when we're moving from thoughts and feelings, I feel, into what do we need to do about it? What do we need to change? And really mapping that against the different themes that come from the discovery and dream phase. So you're moving towards what's actionable. And then deploy is about, well, what do you take forward? You can't do everything, but there's going to be some things that make sense. So in my particular example with the team I worked in, this is actually a picture of the workshop, and the previous picture was as well. We had separate focus groups with experts by experience and those people from adult mental health teams. So they have two different lenses. So you have the focus group through the discovery and the dream phases with staff members that provide care plans. And then you've got the experts by experience, those people who have received the care plan or had a care plan in the past, or maybe currently have a care plan. So it's getting the lens of those people that receive a care plan, those people that provide a care plan. We then used framework analysis, so brought together some of the commonalities across the different themes, and then we had an in-person event. This is the picture that you can see here, where we brought together experts by experience and staff members, and we went through each theme. So we said, well, this is what we got from what you said. And we went through each theme and we got some post-it notes. It's all very technical post-it notes. And we went through each theme and we asked people, what would we need to change? What would we need to implement? What would we need to consider? So moving towards that action. And alongside that, we used something called a prioritization framework, which actually I'll skip to. So when people were giving their post-it notes, and there were lots of really good ideas, and they could be big or small, more often than not, we want something quite specific. And we asked them, if you look to the picture, we asked them to put on each theme whether it was urgent or not, and whether it was important or not. So we could focus on what collectively the group thought mattered. And the themes that we come up with were theme one, so understanding the individual and helping the individual to understand themselves. So this was before the workshop. Collaborative engagement and agency, and harnessing the wider community, which really fits along the integrated approaches that looked at. And from that, these are some of the changes that we generated, and these are the ones that were highlighted as urgent and important. Ignore the typos because we literally just pulled this off there. We literally pulled this off the Word document. We highlighted the areas that went directly into the care plan that was subsequently created. So these are the ideas. The ones that are highlighted then went into the design of the care plan that I'm going to show you now. So this was it, and it's being rolled out across the trust as we speak. These things can take some time. It's been used by several different teams in Oxford Health, which is a mental health trust. And don't worry about reading this because I'll share these slides with you after. Of course, it is recorded, but this was a bit about the information and really how this was created. But I'm going to move on just because I'm watching the time. I want to say a few more bits. And this template was so thoroughly done that it meant that we could map the themes onto the different pages in the care plan. So we could be that transparent. Remember what I said about being transparent about what's being collected, how we've analysed it, and how it moves towards how we design the care plan. So the first, doesn't look very good graphics actually looking at it now, but theme one was about understanding the individual and helping the individual to understand themselves. So the first questions were who I am. I always want to say who am I, which makes it really existential. Who I am, so how the person sees themselves. And the next question is what matters to me. And this is it might not sound that radical, but actually it is quite radical because you're not jumping straight into the care plan. What you're doing, you're starting with a general conversation with somebody. You say, well, tell me about you. Tell me about what matters to you. That's a strength-based approach. And then through that conversation, you can then start picking out, okay, well, what matters to this person? And it means as you go to the next few pages, you don't just go through it in a sequential fashion. Well, we're going to talk about this, we'll talk about that. If they say something like, let me just give you an example. Someone says, I've been really unwell for the last 12 months. I haven't been able to work and I've really struggled getting out of my house because I don't find it easy to see friends. I'm quite isolated. It's really quite difficult. But the thing that really matters to me is that I go at 2 p.m. to the newsagents and I walk through the park. It's coming towards spring now. And I like that walk because it's quiet. I don't have to engage with people. Well, once you start hearing that, you might think to yourself, well, that's leisure activity. You're not going to go into I'm not going to go into friendships or job. You say, okay, well, that walk sounds interesting. Let's start with that. That leisure activity, what does that mean to you? And then it might be that they say, well, I really like the fact that the snowdrops are coming out this time of year. You might say, well, actually, do you know what? We've got a gardening group you might be able to link up with. You might not feel ready just yet, but you might think about that. It might seem like a simple thing, this, but it's actually really quite radical because you're not going through the form. You're having a conversation and making that engagement first, and then you're tailoring the pages you go to next based on what matters. And it doesn't mean you ignore the things that are difficult, but it means you can build that rapport quite quickly. So theme 2, again, you can't see this too well, but basically it provides opportunities to score how people are getting on. That's a mandatory part of care planning that's still in place with something called dialogue. I won't bore you with that too much. But basically these boxes are about, what would you like to see happening going forward? What are the things that matter to you? What may be some of the barriers? So it's about collaboration, engagement, and agency, really helping the person to specify exactly as I gave you with my example, what might be good for them going forward, what small steps might help with their recovery, and in particular, how they can take agency in their recovery journey. And then about harnessing the wider community. So really thinking about how we can connect with different services, how we can think about linking up with maybe community initiatives. Again, that's really important, and that's another aspect that's come within the template that we have. I have a YouTube clip. I'm watching the time and I don't know if I've probably got about 15 minutes, would you say, Claire?
Yeah, so I'd say about 20 minutes.
Oh, really? Brilliant. Okay. So I want to play this. I'm hoping it'll work. If it doesn't, then don't worry, I'll send the slides because the YouTube clip is embedded. But this is a clip of 3 peer support workers. So they're people who have had lived experience that work within one of the services that use this care plan. And they're talking about how they've used this care plan and their views on how it helps with care planning. I'm hoping you'll be able to hear it. Can you hear it?
No.
Hold on.
I can hear it.
You can hear it?
Yeah.
Oh,
yeah.
great. People can hear it.
It says low in here.
I can't hear it. Yeah.
Sorry, can I just mention, I think people who can't hear might not have clicked on the at the bottom where it says to put the can't remember what it is, to put the slides according to the presenter.
I did the cardinal thing of talking whilst I was on mute. Rather than us having some technical difficulties around some people listening to it, some people can't, I'll send the slides. It's embedded in YouTube, so you can watch it at your own leisure. But it's really worth watching because we have people with lived experience that support others. They talk about what the care plan means to them and how it's helped them support patients in the service that they provide. Thank you, Hassan. That's really good. But I think I'll probably just move on. It makes it a bit easier. Okay, so engagement equals impact. And I just want to speak more broadly about this because I think it's something that's emerging within research and traditional research domains, but it's important to consider as we think about how we do translational research and how we do research that matters. So really thinking about the efforts that we make when we're thinking about evaluation, and I sort of put my evaluation experience hat on, and just making sure that evaluation doesn't start after the fact. There's lots of projects where you can almost see it's a bit of an afterthought, and they sort of come in, and actually if you're looking to do particularly applied research, it's important not to do it after, because normally the ship has sailed in terms of the changes that you can make, and also being able to take an iterative approach, which is what I do with my research, where you might be able to find barriers sooner in the pathway of doing research for improvement and be able to make those changes as they happen. Making sure that we have the right people involved at early stages. I've already mentioned this, but engagement really is the golden thread, both in terms of being able to make applied change, but bring people along with you, as I've already said. And it really helps in terms of impact, which we know matter for those people in academia. We know that REF does look in particular at impact cases as much as they do with research. So you have the right people involved, you actually make your life a bit easier if you're doing applied research, because you have them on board, you get their expertise. But it's that, for me, it's the values that come along with that. I look for genuine reciprocity. I want to make changes in the real world, and I don't want to be seen, certainly don't want to be seen as someone in an ivory tower who doesn't really understand what things look like in practice. So, and if you think from the wider look at funding and thinking about, you know, the kind of approaches we want to take maybe with our research, I'm thinking we might have more applied researchers or people interested in applied research here. But certainly from my time, it's quite a few years ago now, but I know that UKRI, so this is the research councils, have a real push towards translational research with tangible impacts. And in particular, there's much more, when I was there, it was 6 years ago now, that was quick. There's much more of a push towards looking at industry partnerships and looking to break down some of those barriers. And you'll see that with NIHR as well, right? So the Innovation for Impact, I think it's called, there's quite a few awards that specifically talk about commercialization of some of the approaches that we take. One of the things I've always liked about NIHR, and the reason why I put a lot of my research towards NIHR, including 3 schools, is there's really a focus on PPIE. And certainly there's been some, and Claire will be able to speak much better to this than me, but there's been much more of a strategic drive towards meaningful engagement within research and really making sure that you can actually have a plan that really does show inclusivity at different stages of your project, which really helps to avoid the tokenism that we can sometimes see in PPIE activities. So we're on take-home messages. If I had the video, then I probably would be in a good position, but I'm a little bit early because we're not playing the 7.5 minute video that I've got. So I love the litmus test, and this is sort of what I started the talk with. I asked you those questions. Have you ever been to a meeting where you didn't know why you're invited? I asked you another question about, have you ever been to talking shops where things don't actually progress? And I think litmus tests are really important when we're doing certainly applied research. Ask yourselves just the really simple questions. How would I feel about this particular intervention? One of the things that I did that I've mentioned is that I worked with the Care Quality Commission. This was on ligature harm reduction. And the reason why I was doing this work, it was about 3 years ago now, 4 years ago now, was that there was an audit tool that had been used with inspecting ligature points by secondary care inpatient services, and they didn't know how it was created. No one was able to really find the origin of it. This is all public knowledge, it's not confidential. And there were lots of people that lost their lives by suicide because of the fact that they had deemed low ligature points as the low-lying ligature points as a low risk. And unfortunately, quite a few people had died as a result. So I was brought in, so the tool was rescinded, and I was asked to come in and do some work on looking at the guidance, and it should be out now if you want on the CQC website, you can see it. But one of the things that I did was I went around and I visited wards, And whilst I did have the evidence, I spoke to experts and people with experience. The thing that I asked myself with the people I was with was a very, very simple question. Would I want my loved ones to be in this particular ward? Would I feel comfortable with them being here? And I just kept asking myself that question when I was looking at the ways in which things are set up. You know, the access to natural light, access to natural spaces, the personalized approach, whether it was there or not. So when you're looking to do applied research, really think to yourself, what the litmus tests and questions that you should be asking yourself about what this might mean. And if you do feel a bit uncomfortable about what you're doing, think about why that might be and who you might need to have involved in those conversations. As I got a bit more time, I'll mention another anecdote just very quickly, because I think this is also another good one. Last December, so 2023, yes, 2023, I was asked to conduct a compassion workshop with an inpatient team that had had a couple of serious incidents, and I needed to go and speak to them for the day. It's about how we can increase compassion. And that's difficult, right? I had the whole team there, probably about 30 of them, everyone from directors of nursing down to support workers and cleaners. So it was difficult because I'm going there to say, well, we need to improve how we care, which is really insulting because, well, they do care. That's the reason why probably a lot of them are working in healthcare. But the way I approached it is quite similar to what I've just mentioned. So the first question I asked to all of them, to about 3/4 of an hour, but it's worth doing, was, I don't really want to know what your job title is. I want to know what your name is and what brought you into mental health. What's the reason? And we went through, and of course, everyone had very, very similar reasons. Some people have lived experience, some people had caring experiences supporting relatives. Some people, they just found it was a calling that they had. So that immediately got everyone on the same page. We had, everyone was talking about why they were motivated to be there. And then the next question, before we even got into what we could improve, I asked them the question, similar here, and similar to what I thought about when I did the ward rounds. I said, if your loved one come into your service, what would you want that care to look like? Tell me about what you'd want them to receive. I want you to tell me the details. So we're starting from that point of, well, what do you want for the people you care for? What do you want that to look like? And that I won't say any more details, but that opened up the conversation for thinking about how they can do things better. And when we think about meaningful engagement, if I went in there and said, look, you've got serious incidents, this is a problem, you need to fix this. Well, of course, I'll look at me and say, who the hell are you, David? You've come along, we care, you don't know what we need to deal with. But when you start it with that question, that's really important for getting that meaningful engagement. So I just want to reiterate a few things. When people give you their time, like you've given me your time today, it's a blessing. I'm blessed to have you guys here listening to me talk about something that matters to me. So when you come, I want to make sure, and hopefully you'll think this, that this was worth coming to, it was worth your time. I'm hopefully using your time wisely to listen to this. Think about that in terms of your research. More often than not, I've supported a lot of teams that don't have the idea of what they want going forward and then working backwards. Sometimes they're focused so much on the questions they want to ask in focus group, they're not thinking about, well, what do they need from that, and then designing the question backwards. So that's really important, particularly in applied research, because it will help your engagement. Well, we're hoping to get here and we need your help, and let's think about what we need to do to be able to get there. So don't ascribe to this idea that everyone needs to be involved in everything all the time. They don't. Inclusivity, when it comes to PPIE, isn't about dragging everyone into every single meeting. Be really aware of the fact that you want to think about how people are involved and why they're involved. So be strategic. And if they are coming along, make sure they understand why they're being involved. Don't forget to be really explicit when it comes to acknowledging and celebrating the involvement of all involved. You'd be amazed the difference it can make when you've got a support worker or maybe the person who's never come to a meeting like this before, and you point them out and say, maybe not make them embarrassed, you point out and say, really appreciated you being here. Your words will carry weight, so don't forget that. And there are huge benefits. honestly, this care plan that we've created and the ways in which we have that transparency. So if you think about it from what was created, we had conversations with people with lived experience, people with staff. We brought together the commonalities of what mattered to them, and then we focused on each of those themes. And then we went into what do we need to do about it, what's urgent and what's important. And we're so transparent that we can go from the conversations we've had right the way to the actual page within, or the pages within the care plan. So if anyone ever come to us and say, well, why did you do that? We could literally track it. We could literally say, well, this seems to matter from people with lived experience and staff members. They agreed on this. This is what they thought mattered, why it's urgent, why it's important, and this is how it manifested on the care plan. So there's not that black box that I mentioned that I laughed about without my lovely stock images. But on a serious note, there's not that black box with this kind of work. You have that transparency. That's really important, and that makes people feel valued. So think about that transparency when you're doing this kind of research. Okay, so that's me done. A little bit earlier. I hope that was enjoyable, and I'm going to unshare slides and I'll pass over to you guys if you have any questions.
Thank you so much, David. Well, how did you phrase it at the beginning? A sermon, that was it, wasn't it? I was thoroughly interested in the sermon, I must say. Particularly fascinated by your history, you know, your background, your academic background, and also your personal history. So thank you for sharing that with us. And I'm sure everybody will agree it struck a chord what you were saying about exactly why it all matters. So I don't know if anybody has got any questions for David at all, or any comments.
Or that from Georgina, I'm happy with
Got a clap.
that.
There we go. I thought that was for me.
Yeah, it might be.
Has anybody got any questions, comments at all for David? I wonder if you've stunned people into silence.
Well, it could have been. It could
Could
have
have
been. I
been.
get a bit passionate about these
Oh,
things.
not at all. I don't think you can be passionate enough about this topic. And we will be sharing a copy of the slides after on the website together with the recording as well. So people will be able to look at those and also take a look at the YouTube video. Oh, Georgina's typing.
Yeah, I see someone's typing.
I was just going to say thank you, David. I mean, some of the things that you've said, you would think, yeah, we should know that. But the way that you've presented it today was really, really interesting. So thank you very much for taking the time to do it for the 3 Schools programme.
No, pleasure. I think the thing is, that a lot of it can seem obvious. That can be very different to what people actually do.
Absolutely, yeah,
And
I agree.
I think that's the thing.
Yeah.
For me, it's about being explicit with people's involvement. I think more often than not, you know, if you're busy and, you know, you have lots of meetings and you don't necessarily take the time to think about who's there, it's that litmus test. It's that if they turn up at the end they're thinking, and we've all had it, right, haven't we? They're thinking, I don't know why I was there. Like, I don't know what they wanted from me.
And then you start
we're used to it.
questioning yourself because you think,
yeah.
you know, was I missing the point? Should I have said something? But
And for me, it's when you've got people with lived experience, and that might have not been the meeting they needed to come to.
yeah, lots of comments coming through, people saying thank you, lots of key points to take on.
Brilliant.
Yeah, really inspiring. It's another one.
Well, good.
Philippe Evans is questioning, I'd love to hear your thoughts on how to practically engage healthcare professionals when a lot of healthcare systems are stretched and time, as you say, is such a precious resource.
Yeah, really good question. And this comes down to the almost the negotiation between what needs to be done versus what staff members want to do. And giving them the opportunity to do that. So if, as an example, the work that I've done with the Specialist Eating Disorders Unit, that was looking at how we can increase the experience of mealtime support, which is an area that has no guidance on at all. In fact, the Royal College of Psychiatrists, their guidance is make it therapeutic. I'm not entirely sure what that even means. But we did that project during the pandemic, and they had the acuity in eating disorders really went up. There are people with BMIs of single digits. Give you an idea of how unwell. So this is the tertiary care. So it's above secondary care. And even though they were busy, giving them the opportunity to do change alongside their work gave them a bit of a focus away from the drudgery of the kind of patients that they were supporting. So you're absolutely right that we need to think about the time and spending it wisely. And if there is a change, that they're supported to do that change. In particular, that thinking about the burden that the change brings. Because if it is something that can be done that will actually help them in the long run, that should be considered. But what I have noticed, certainly over the pandemic, was you'd be surprised the benefits that can come from it if you tap into something that matters to them, and they can do that without it increasing the additional admin type stuff that they need. I can give a lot more detail about that in the future, Philip, if you want, because it was one of my jewels in the crown. That particular project ended up with national guidance being created with HE. That one.
Fantastic. Well, if we haven't got any further questions at all, we'll call it to a close, if that's okay with everyone. So once again, thank you so much, David, on behalf of the 3 Schools Mental Health Programme, and it's been fascinating. Thank you.
Brilliant. Thanks very much, everybody, and thanks so much, and I hope it was enjoyable.
It was.
Thanks, David.
Thank you.
Cheers, guys.
Thanks, David.